This is Glenn Robinson, President of the World Affairs Council of the Monterey Bay Area. I would like to welcome you to our newest edition of Quick Takes on International Affairs. Please enjoy this talk and do consider joining the World Affairs Council.
Hello, I'm Victor Rodwin, speaking to you on July 23rd from Vermont, where 2 days ago we peered out at the smoke coming in from California. I couldn't resist the challenge given to me by the World Affairs Council to come up with some lessons for Americans from the comparative analysis of health systems. But as soon as I began thinking about this, I bumped my head against two problems. First, how to agree on lessons given the polarization that characterizes our society today, where we can hardly agree on the facts, let alone how to interpret them. And secondly, a problem I faced throughout my whole career, which is whether or not it's worthwhile to compare healthcare systems to begin with. The argument is often made that every health system is unique. It has its own history, its own institutions, its own values and culture, and therefore it's extremely difficult to transport lessons from other nations. We call this American exceptionalism in the United States. But the Swiss have their own version of exceptionalism, and so do the French, and so do the British, and so forth. And the second argument, which has some truth to it, is that a great deal of comparative analysis is really no more than painting an image which caricatures a system abroad in order to advocate what one does not want at home, or to advocate exactly what one proposes to have at home. For example, the British National Health Service is often used when problems are pointed out to warn Americans against the dangers of a national health service, sometimes wrongly called socialized medicine. Or others look to the National Health Service in ways that it works very well with no price at the point of consumption as a great example to follow for the United States. So these caricatures have weakened the field of comparative analysis of health systems, which is known to rely even more than other fields on the selective use of evidence. So given these problems, what I've decided to do is present to you at least lessons that I believe I have learned over the course of 35 years of teaching and doing research at New York University, trying to understand healthcare systems abroad, as well as our own system at home. So I will move quickly given the time constraints for this video series. The first lesson, and that's something I wrote about when I first started in a book called The End of an Illusion, The Future of Healthcare in Western Industrialized Nations. That first lesson is that all healthcare systems ration healthcare through various combinations of triage or medical need or first come, first served, or cost effectiveness considerations. Managed care in the United States is nothing more than a rationing device. Or most countries through various political processes, more or less accountable to the public. And of course, every country, but more so than all other countries, rationing occurs through price. In the United States, prices on the private insurance premiums that people pay and on the out-of-pocket payments that they pay. Second lesson is that there is no one best healthcare system. Clinical stories, whether they are told by doctors or by patients, are rarely representative of the whole. And health systems, by their very nature, are characterized by enormous variation in patterns of care across small geographic areas, across groups of people, groups of physicians, groups of patients. And so it's really very hard to say something general about any healthcare system. some people try to draw averages based on statistical analysis and then take those averages of all kinds of discrete indicators, life expectancy at birth, waiting times, outcomes of different kinds, and they aggregate these discrete indicators into some composite ranks. But that too is dangerously misleading, because how you aggregate that and how you design the composite indicators really has to do is a very subjective exercise in weighting the relative importance of the different criteria. Lesson number 3, the U.S. health system really does stand out among wealthy nations as the only one without universal coverage of the population, irrespective of employment status, age, or income. Now, in thinking of universal health insurance, I think it's important to emphasize that there are 3 important dimensions. And whenever anybody talks about universal, ask them who is covered, what is covered, and how much is covered. Some systems like Canada cover everybody, but they don't cover dental care. They don't cover pharmaceuticals very well. And then there's a question of how much you have to pay. In Canada, there's very little first dollar payment for what's covered. But in Switzerland, everybody's covered, and they're covered for a generous benefit package, but the out-of-pocket costs are enormous. Lesson number 4, the assertion that the U.S. has a free enterprise, entrepreneurial, market-based healthcare system, in contrast to most other government-run systems, is false. I think there we have to speak with more nuance. And it's useful to draw a few distinctions in talking about health systems in wealthy nations. First, there's a tradition of Bismarck national health insurance, originally begun in Germany in 1883. That's a system financed largely on payroll taxes. Then there's a whole set of countries that have national health service systems, inspired largely by Lord Beveridge, and the system was implemented in Great Britain in 1948. Portugal, Spain, Greece have systems resembling this, as well as the Nordic countries. Then there are 2 other recent kinds of models, Switzerland and Netherlands, which have private health insurance, but it's universal because there are national mandates that require that everybody be covered and that everybody follow the same rules in terms of reimbursement prices for all the payers. So there are variations with different forms of managed competition, more or less market-based, but there's also very strong government regulation in these systems. And then, of course, we have our system, which is the most fragmented and diverse system probably in the world, because we have an enclave of socialized medicine called the Veterans Health Administration, which is entirely funded by the government and provided by the government. We also have systems that you know in California, Kaiser Permanente, Aetna Health Insurance around the country, United Healthcare, Intermountain Healthcare, Mayo Clinic, Blue Cross. The variations are enormous. And this next table allows one to classify different kinds of financing in the columns and different kinds of provision in the rows, so that the first box, government financing and government provision, is the definition of socialized medicine, which exists, so far as I know, in only 1 country in the world today. Because a national health service is financed by government, but is not located only in this first box. There is also private care in Great Britain, and GPs are autonomous professionals who are paid for by government, just as American autonomous professionals are paid for by government. They're paid in different ways, but that's not socialized medicine. That's a national health service. And then those countries financed on the basis of payroll taxes, mandatory payroll taxes, are known as health insurance, national health insurance systems. And then private health insurance can either be entirely voluntary or can be required, as in Switzerland and Netherlands. In the United States, is a combination of both. And out-of-pocket payment is much less important in the wealthy nations, which have largely socialized the financing function. In contrast to most people in the world in poorer countries who have to pay for healthcare entirely out of the pocket. So the US system, with its very strange fragmentation compared to universal health insurance systems, has about half of the population covered, as you see in slide number 8, by employers. But there's great diversity within employer coverage as well. Public employers, private employers, large employers, small employers. And then there are those who pay for insurance privately who get the worst deals because they cannot negotiate. And then there's Medicare for 14% of the population, 65 and over, and those with severe disabilities, and those with kidney, end-stage kidney disease. So we're the only country in the world that provides universal health care at any age, but just for one organ, the kidney. A strange situation, but that's a characteristic of our system. And then we have Medicaid for the very, very, very poor in this country, run by 50 different states in very different ways with different eligibility standards. And we still have 10% of the population uninsured. And that doesn't speak to the fact that many of those covered by employers are not well insured. Lesson 5. We spend more on healthcare as a percent of GDP for many reasons, but mostly due to higher prices. Part of our increased spending, you can see, is due to the fact that over the last 40 years, when even in 1980, we spent more as a percent of GDP than most other wealthy nations, that gap has grown, as you can see in this chart. Another reason for high spending in the United States is that we have a very high proportion of medical specialists who, by their nature, have to order specialized tests, prescribe specialized pharmaceuticals, and therefore cost the system more. We use a great deal of medical technology, not more so than all other countries. There are many countries that use as much as we do, depending on the technologies. We have more administrative costs and administrative technology than most other nations. Some estimates suggest that almost 20% of all healthcare spending is due to administration, some of which is useful and some of which is not, some of which simply reflects the fact that we have thousands of different payers who follow different reimbursement rules. But the really most important reason for our extraordinarily large spending is due not to higher volume of services delivered. You can see here that we have fewer hospital admissions per capita and fewer physician consultations per capita, even though we spend more as a percent of GDP. The real reason is that we have higher prices. Why higher prices in the United States? And by higher prices, I mean higher wages for everybody and higher prices for all goods and services in healthcare. In comparison to other wealthy nations, study after study has found that our prices are higher and explain the large spending on GDP. And so the way this looks from an accounting perspective is that we spend more than most countries just in terms of public expenditure, with the exception of Norway and Germany that spend more on public expenditure. But the biggest difference is this orange part of the graph of slide 12, where we spend so much more on private expenditure. And that's largely expenditure on private insurance and the payments by private insurers. We also spend more out of pocket as a percent of total spending, with the exception of Switzerland, which outdoes the United States. Lesson 6, We should not assess the performance of health systems based only on life expectancy at birth. All of you have no doubt read, as I have, the fact that we spend more than every other country, and yet we have the lowest life expectancy at birth. It's actually gone down in the last few years, as all of you must have read, due partly to COVID and to opiates. But even without that, our life expectancy is less than other wealthy nations. And some people say, we conclude our health system is terrible because of that. I don't conclude that. We still have very good enclaves of healthcare, and the fact that our life expectancy is lower than in other countries is not so much a function of our healthcare system. It mainly reflects the fact that we are the most obese nation in the world, and we have very high rates of poverty. I'm talking about wealthy nations, and we have some of the most inequitable income distribution and wealth distribution among wealthy nations, and we have low levels of education compared to some of the European nations, and this low life expectancy at birth also reflects neighborhood of residence and conditions in our neighborhoods and housing conditions. So it's wrong to attack health systems based on this criteria. Just so you see some of the tables with respect to COVID here, on slide 14, you see US with the highest obesity rate and also the highest COVID death rates per million residents. And that reflects, that's just further recent evidence, timely evidence on the impact of obesity on population health. Also, just to back up what I said about inequality of incomes, when you have more time, you can study this table or this graph and see that even after we redistribute income, we have more income inequality than almost all of the other wealthy nations. Lesson 7, although we spend more than any other nation on healthcare, we spend much less on social care, by which I mean early education, family support, sickness cash benefits, old age pensions, and disability. So you see here that although we spend much more on healthcare, 16% in 2013, almost 20% in a few years, we only spent in 2013 9% on social care, which is very low spending compared to other wealthy nations. Lesson 8, our healthcare system performs poorly in caring for the whole US population. We have poor access to primary care as measured by avoidable hospitalizations. We have avoidable hospitalizations means people who end up in the hospital who, because they did not receive timely and effective primary care, came in with exacerbated conditions which required hospitalizations. And that's an indication that people are not getting access to primary care as they should and do in countries that do a better job and have lower rates than we do of avoidable hospitalizations. We have, according to surveys by the Commonwealth Fund and others, very high financial barriers to access compared to other wealthy nations. And even after President Obama's Affordable Care Act, we still have, even more so perhaps, highly restrictive networks limiting where patients can go, which is another form of rationing US style. And survey after survey over the last 25 years have shown that we have very low levels of satisfaction with the overall healthcare system in comparison to other nations fielded with the same surveys. Most importantly, we have among the highest rates of what's known as avoidable mortality. That is to say, premature death prior to 75 years old from diseases that are amenable to screening and medical intervention. For example, ischemic heart disease, several malignancies of the breast, colon, cervix, skin, tuberculosis, maternal deaths. No one should die from these conditions, or at least fewer people should die from these conditions if they live in a country which makes healthcare and basic prevention services available in a timely basis. Just so you can see the tables and the evidence on this, the U.S. has the highest rate of avoidable mortality, and Switzerland has the lowest rate of avoidable mortality. Lesson 9, and I have to go fast here because time is running out. Viewed as a sector of the American economy, the healthcare system is a great source of employment growth and a great source of exports. I think of pharma, I think of medical devices, I think of hospital management, and I think of all kinds of innovations that we export around the world, which makes our healthcare sector a very successful economic sector. It's really big business in the United States. Lesson 10, despite calls for reform, despite calls to really achieve universal access, not just of the population, but also in the other two dimensions that I mentioned, the axis of opposition to reforms, private insurance industry, private not-for-profit hospitals, as well as investor-owned hospitals, and big pharma, create a stakeholder team of lobbyists and powerful forces that resist any kind of change. I would venture to say that the political antibodies excreted against any attempt to change the US health system are even more powerful or pale compared to the antibodies that go against an attempt at organ transplantation. And so on that note, the question is, what is to be done and where do we go from here? And that, of course, is the topic of another video at another time. Thank you very much for your attention.